And welcome back. I'm Mabel, Jong. You're watching WHCC TV. Thank you so much for joining us. We're coming to you live from Washington, D.C., from the World Healthcare Congress. And you may remember our guest when he was with Lake Norman Benefits, and he is back in the studio to talk about his new company. Welcome to David Contorno. How are you doing?
I'm doing well, Mabel. Thank you. How are you?
Well, just 8 months ago, you founded ePowered Benefits. That's your new venture?
That's right.
So tell me first a little bit about the name of the company.
Well, we wanted everything to be employee-centered. So we sort of took the E to say that everything is focused on the employee, which, if you look at it from the healthcare perspective, is the patient as well. And we do that with expert advice and through the employer market. So the E just sort of felt like it flowed.
Okay. And what is the focus of the company now? What kind of work are you doing?
Well, our clients are still the employers, so in the sense that we're still advising the employers, that hasn't changed. What has changed dramatically, though, is where our revenue comes from. In the traditional model, a broker or consultant's revenue is typically coming from the carriers, the stop-loss carriers, the fully insured carriers. There's a lot of bonuses and overrides that are paid for production and meeting goals that the carriers want you to meet. The challenge is that those goals are typically at odds with what the clients want you to meet. And so when you're in a world where you're being paid by the carriers, but you're representing the client, I see a very strong conflict of interest. And this new venture allowed me to break free of all the revenue coming from all the other sources other than our clients. So now our full revenue comes from our clients, and we create bonus structures with their buy-in that they pay us a bonus when we reach the goals they want us to achieve. And all of a sudden, those goals become a lot more likely to be achieved when the incentives are aligned.
Right. And does that mean a much more transparent, open system?
It has to. So the transparency started in how we get paid, but because the goals now, through that transparency, were tied to improving outcomes and lowering costs for the employee population, we had to build a transparent environment for the health plan itself to see, measure, and monitor that.
Okay. What sort of concerns or trends are you seeing from both the parties that you work for?
Well, I think that in general, the trend that I think is really the newest trend going on is direct to employer contracting. And there was an article last year in the Wall Street Journal about how General Motors did a direct contract with Henry Ford Medical Center, and it's going to save them $25 million without changing anything except getting a whole bunch of the middlemen out of the way. And that really inspired me to push even harder and say, let's reach out to these health systems. And you know what I found? Is the health systems oftentimes are wanting to do it as well, because they don't like all the middlemen in between as well. And doctors, they don't like all the middlemen either. And so you start to realize that this middlemen, which are the carriers, the networks, and the PBMs, and some brokers out there, they're not adding value, they're extracting value from everyone. And when you start to get as many of those out of the way and then turn the incentives around to reach the goals the clients want you to reach, it actually becomes relatively easy to build a high-functioning health plan, at least in comparison to what they have today.
So really direct contracting is what you're finding is bringing in the most success.
That's right, because then you don't have to worry about the hospital or doctor saying we don't know your plan, and you have a prearranged, mutually beneficial relationship.
Okay. What are some of the barriers to growth with that? It sounds good, it makes sense, but there must be a catch.
There are some challenges. It's a negotiation, so it really depends on the scenario. If you're talking to a rural hospital system where they're the only option, it really is going to depend. Are they really community focused, in which case they should be very open to it, and some of them are? Or do they think, well, we have a lock on this market, so why are we going to agree to anything outside of what we already know and understand? And it really can go both ways. But if you get into a market where there's more competition, some areas like Charlotte, where I live, has two dominant systems. Other places like Western PA have a single dominant system with the smaller systems around it. And so again, the conversations change. We've gone to the smaller systems, which, by the way, typically provide higher quality and lower cost care, even though the larger systems do more marketing and therefore the public thinks it's the opposite. But when you approach those smaller systems, you not only wind up building into the plan a system that is higher quality and lower cost, but you can then create leverage against that larger hospital system.
Oh, okay. What has been slow to adopt? I mean, it sounds like it's still a learning process for all of the parties involved. So what is keeping from more people adopting this?
I mean, the part of this is going to sound similar to probably what I said last year and even the year before, is that I think the biggest challenge is that in the United States, we intermingle the words healthcare and health insurance as though they're one and the same.
Yeah.
And so the challenge I have is I'm trying to tell people, well, if we fire the carrier that you feel you're comfortable with, they don't provide any health care. I mean, with the exception of a company like Kaiser, but most carriers, they're helping us pay for health care, but they're not actually delivering or providing any health care. And so I'm not saying go to a different doctor. Do you think that if you go to a hamburger place and you order the same burger, is it different if you show an American Express card versus a Visa? No, you get the same burger, right? Well, the same thing is true when you go to a doctor and you show one ID card versus another. Do you think he gives different medical advice? Matter of fact, I'd argue in the traditional model, the traditional carriers put so many restrictions on those doctors, and whereas we give the doctors more control, they have an easier time in our model, not a harder time.
Right, right. And do the doctors agree with that as well?
Again, there's a mix out there. I mean, there's a lot of people who are just hanging on to what exists today really tightly, but I think that group is shrinking. It's still the majority, but I think it's shrinking and shrinking. And we're working with larger and larger employers to build these type of plans that don't have big carriers behind them. And I think as larger employers do it, some of the smaller employers will feel comfortable, but larger employers are also slower to do it. So we're trying to work it as a mix from the large side and the small side, and then hopefully meet it in the middle.
David, it's always great to check in with you. What do you predict our conversation will be about the next time we speak?
I hope that the next time we speak, there is a significant shift in the large carrier approach to the market, because ultimately they're going to have to change. The question is, are they going to change because they have to and they're forced to and they're literally losing market share? Or are they going to take the responsibility that I think they should have as the predominant way that we pay for care in this country and start to really care about the cost and quality of care that their members are receiving instead of the shareholders, instead of the executives' compensation, which is clear to me that that's all that they care about, even though their marketing message is very different. Their results are very clear. The results speak to everything. Our healthcare system is getting worse in quality and higher in cost to a degree that we should be ashamed of. And I hope that by next year there's a carrier that says, you know what, we're going to find a new revenue model that allows us to be profitable in a way that benefits the patient, and that's what we're going to focus on.
Okay, well, stay tuned. Thank you so much for your time, David.
Thank you.
David Contorno of ePower Benefits. Meanwhile, we have many more interviews to come, so stay tuned with us.